understanding of intracranial pressure, let's move on to head injury. Head trauma has a high potential for a poor outcome. Deaths from head trauma occur at 3 time points after injury: immediately, within 2 hours, and about 3 weeks after the injury. The majority of deaths after a head injury occur immediately after the injury, either from direct head trauma or from massive hemorrhage and shock. Deaths occurring within a few hours of the trauma are caused by progressive worsening of the head injury or internal bleeding. Immediately recognizing changes in neurologic status and rapid surgical intervention are critical in the prevention of deaths. Deaths occurring 3 weeks or more after the trauma result from multisystem failure. Expert nursing care in the weeks following the injury is critical in decreasing the mortality risk and in optimizing patient outcomes. KD is a 33-year-old woman who was brought to the emergency department by paramedics following a motor vehicle collision. She has a laceration to her forehead and bruises from her seatbelt. She has a closed head injury secondary to trauma during the motor vehicle crash. She is stuporous and does not answer questions. What's the most likely cause of her change in level of consciousness? It would be the closed head injury, right? Scalp lacerations are an easily recognizable type of external head trauma. Because the scalp contains many blood vessels with poor constrictive abilities, most scalp lacerations are associated with profuse bleeding. So just for your information, a peri-pad is a really good dressing for on-the-scene pressure application with scalp lacerations. Even relatively small wounds can bleed significantly. The major complications associated with the scalp laceration are blood loss and infection. Skull fractures frequently occur with head trauma. There are several ways to describe skull fractures: linear or depressed, simple, comminuted, or compound, and closed or open. Linear fracture occurs when there is a break in continuity of bone without alteration in relationship of parts. It's associated with low-velocity injuries. A depressed skull fracture is an inward indentation of skull and is associated with a powerful blow. Remind me to tell you about my dove. A simple linear or depressed skull fracture is without fragmentation or communicating lacerations. It is caused by low to moderate impact. A comminuted fracture occurs when there are multiple linear fractures with fragmentation of bone in many places. It's associated with direct, high momentum impact. An example of a compound fracture is a depressed skull fracture and a scalp laceration with communicating pathway to intracranial cavity. This is associated with severe head injury. Fractures may be closed or open depending on the presence of a scalp laceration or extension of the fracture into the air sinuses or dura. The location of the fracture determines the clinical manifestations. The major potential complications of skull fractures are intracranial infections and hematoma, as well as meningeal and brain tissue damage. It's also important to note that in cases where a basal skull fracture is suspected, a nasogastric or oral gastric tube should be inserted under fluoroscopy. A basilar skull fracture is a specialized type of linear fracture that occurs when the fracture involves the base of the skull. Manifestations can evolve over the course of several hours, vary with the location and severity of the fracture, and may include cranial nerve deficits, battle sign, postauricular ecchymosis. Should I say battle sign is postauricular ecchymosis, and periorbital ecchymosis or raccoon eyes. This fracture generally is associated with a tear in the dura and subsequent leakage of CSF. Rhinorrhea, or CSF leakage from the nose, or otorrhea, CSF leakage from the ear, generally confirms that a fracture has transversed the dura. Rhinorrhea also manifests as postnasal sinus drainage. The significance of rhinorrhea may be overlooked unless the patient is specifically assessed for this finding. The risk of meningitis is high with a CSF leak, and antibiotics should be administered to prevent the development of meningitis. Two methods of testing can be used to determine whether the fluid leaking from the nose or ear is cerebrospinal fluid. The first method is to test the leaking fluid with a dextrostick or test tape strip to determine whether glucose is present. CSF gives a positive reading for glucose. If blood is present in the fluid, testing for the presence of glucose is unreliable because blood also contains glucose. In this event, look for the halo or ring sign. To perform that test, allow the leaking fluid to drip onto a white gauze pad or a towel and then observe the drainage. Within a few minutes, the blood coalesces in the center and the yellowish ring encircles the blood if CSF is present. Note the color, appearance, and amount of leaking fluid because both tests can give false positive results. Brain injuries are categorized as diffuse or focal. In a diffuse injury, like a concussion or diffuse axonal injury, damage to the brain cannot be localized to one particular area. In a focal injury, such as a contusion or a hematoma, damage can be localized to a specific area of the brain. Brain injury can be classified as minor or moderate and severe. And you can see the Glasgow Coma Scale scores associated with each of those. Diffuse injury, such as concussion, a sudden transient mechanical head injury with disruption of neural activity and a change in level of consciousness, is considered a minor diffuse head injury. The patient may or may not lose total consciousness with this injury. Typical signs of concussion include a brief disruption of level of consciousness, amnesia regarding the event, and headache. The manifestations are generally of short duration. If the patient has not lost consciousness, or if the loss of consciousness lasts less than 5 minutes, the patient is usually discharged from the care facility with instructions to notify the healthcare provider if symptoms persist or if behavioral changes are noted. Post-concussion syndrome may develop in some patients and is usually seen anywhere from 2 weeks to 2 months after the head injury. Symptoms include persistent headache, lethargy, personality and behavioral changes, shortened attention span, decreased short-term memory, and changes in intellectual ability. This syndrome can significantly affect the patient's abilities to perform activities of daily living. Although concussion is generally considered benign and usually resolves spontaneously, the symptoms may be the beginning of a more serious progressive problem, especially in a patient with a history of prior concussion or head injury. At the time of discharge, it's important to give the patient and the caregiver instructions for observation and accurate reporting of symptoms or changes in neurologic status. Diffuse axonal injury, or DAI, is widespread axonal damage occurring after a mild, moderate, or severe traumatic brain injury. The damage occurs primarily around axons in the subcortical white matter of the cerebral hemispheres, basal ganglia, thalamus, and brainstem. Initially, diffuse axonal injury was believed to occur from the tensile forces of trauma that sheared axons, resulting in axonal disconnection. There's increasing evidence that axonal damage is not preceded by an immediate tearing of the axon from the traumatic impact, but rather the trauma changes the function of the axon, resulting in axon swelling and disconnection. The process takes about 12 to 24 hours to develop and may persist longer. The clinical signs of DAI are varied, but may include a decreased level of consciousness, increased intracranial pressure, decortication or decerebration, and global cerebral edema. About 90% of patients with DAI remain in a persistent vegetative state. Patients with DAI who survive the initial event are rapidly triaged to an ICU, where they will be vigilantly watched for signs of increased intracranial pressure and treated for increased ICP. Focal injury can be minor to severe and can be localized to the area of injury. Focal injury consists of lacerations, contusions, hematoma, and cranial nerve injuries. Lacerations involve actual tearing of the brain tissue, and often occur in association with depressed and open fractures and penetrating injuries. Tissue damage is severe, and surgical repair of the laceration is impossible due to the nature of brain tissue. Medical management consists of antibiotics until meningitis is ruled out and preventing secondary injury related to increased intracranial pressure. If bleeding is deep into the brain tissue, focal and generalized signs developed. Intracerebral hemorrhage is generally associated with cerebral laceration. This hemorrhage manifests as a space-occupying lesion accompanied by unconsciousness, hemiplegia on the contralateral side, and dilated pupil on the ipsilateral side. Subarachnoid hemorrhage and intraventricular hemorrhage can also occur secondary to head trauma. A contusion is a bruising of the brain within the focal area. It is usually associated with a closed head injury. A contusion can contain areas of hemorrhage, infarction, necrosis, and edema, and frequently occurs at a fracture site. With contusion, the phenomenon of coup contra coup injury is often noted and can range from minor to severe. Damage from coup contra coup injury occurs when the brain moves inside the skull due to high energy or high impact injury mechanisms. Contusions or lacerations occur both at the site of the direct impact of the brain on the skull, which is coup, and at a secondary area of damage on the opposite side away from the injury, contra coup, leading to multiple contused areas. Contra coup injuries tend to be more severe, and overall patient prognosis depends on the amount of bleeding around the contusion site. Contusions may continue to bleed or rebleed and appear to blossom on subsequent CT scans of the brain, which worsens neurologic outcome. Neurologic assessment may demonstrate focal as well as generalized manifestation, depending on the size and location of the contusion. Seizures are a common complication of brain contusion, especially in the first 7 days of injury. Anticoagulant use and coagulopathy are associated with increased hemorrhage, more severe head injury, and a higher mortality rate. This is especially important when considering older individuals who are taking Coumadin or aspirin at home. If a fall occurs, their contusion is likely to be more severe due to the use of anticoagulants. Thus, risk for falls should be assessed. An epidural hematoma results from bleeding between the dura and the inner surface of the skull. The epidural hematoma is a neurologic emergency and is usually associated with a linear fracture across the major artery of the dura, causing a tear. It can have a venous or an arterial origin. Venous epidural hematomas are associated with a tear of the dural venous sinus and develop slowly. With arterial hematomas, the middle meningeal artery lying under the temporal bone is often torn. Hemorrhage occurs into the epidural space, which lies between the dura and the inner surface of the skull. Because this is an arterial hemorrhage, the hematoma develops rapidly. An emergency CT scan on KD reveals an epidural hematoma. What is an epidural hematoma, and what type of emergency treatment would you expect the healthcare provider to order? Classic signs of an epidural hematoma include an initial period of unconsciousness at the scene, with a brief lucid interval followed by a decrease in level of consciousness. Other manifestations may be a headache, nausea and vomiting, or focal findings. Rapid surgical intervention to evacuate the hematoma and prevent cerebral herniation, along with medical management for increasing intracranial pressure, can dramatically improve outcomes. This is a picture of an epidural hematoma covering a portion of the dura. Multiple small contusions are seen in the temporal lobe. A subdural hematoma occurs from bleeding between the dura mater and the arachnoid layer of the meninges. A subdural hematoma usually results from injury to the brain tissue and its blood vessels. The veins that drain from the surface of the brain into the sagittal sinus are the source of the most subdural hematomas. Because a subdural hematoma is usually venous in origin, the hematoma may be slower to develop. However, a subdural hematoma may be caused by an arterial hemorrhage, in which case it develops more rapidly. Subdural hematomas may be acute, subacute, or chronic. An acute subdural hematoma manifests within 24 to 48 hours of the injury. The signs and symptoms are similar to those associated with brain tissue compression and increased intracranial pressure, and include decreased level of consciousness and headache. The size of the hematoma determines the patient's clinical presentation as well as prognosis. The patient's appearance may range from drowsy and confused to unconscious. The ipsilateral pupil dilates and becomes fixed if intracranial pressure is significantly elevated. Blunt force injuries that produce acute subdural hematomas may also cause significant underlying brain injury, resulting in cerebral edema. The resulting increase in intracranial pressure from the cerebral edema can cause increased morbidity and mortality risk despite surgical intervention to evacuate the hematoma. A subacute subdural hematoma usually occurs within 2 to 14 days of the injury. After the initial bleeding, a subdural hematoma may appear to enlarge over time as the breakdown products of the blood draw fluid into the subdural space. A chronic subdural hematoma develops over weeks or months after a seemingly minor head injury. Chronic subdural hematomas are more common in older adults due to a potentially larger subdural space as a result of brain atrophy. With atrophy, the brain remains attached to the supportive structures, but tension is increased, and it's subject to tearing. The larger size of the subdural space also accounts for the presenting complaint to be focal symptoms, rather than the signs of increased intracranial pressure. Chronic alcoholics are also prone to cerebral atrophy and subsequent development of subdural hematoma due to an increased incidence of falls. Delay in diagnosis of a subdural hematoma in the older adult can be attributed to symptoms that mimic other health problems in persons of this age group, such as somnolence, confusion, lethargy, and memory loss. The manifestations of subdural hematoma are often misinterpreted as vascular disease such as stroke or transient ischemic attack and dementia. An intracerebral hematoma occurs from bleeding within the brain tissue and occurs in approximately 16% of head injuries. It usually occurs within the frontal and temporal lobes, possibly from the rupture of intracerebral vessels at the time of injury. The size and location of the hematoma is a key determinant of the patient's outcome. This picture shows the different anatomical locations of epidural, subdural, and subarachnoid hematomas. As for diagnostic studies, CT scans is the best diagnostic test to evaluate for head trauma because it allows rapid diagnosis and intervention in the acute care setting. MRI, PET, and evoked potential studies may also be used in the diagnosis and differentiation of head injuries. An MRI scan is more sensitive than the CT in detecting small lesions. Transcranial Doppler studies allow for measurement of cerebral blood flow velocity. A cervical spine X-ray series, CT or MRI of the spine, may also be indicated since cervical spine trauma often occurs at the same time as head injury. In general, the diagnostic studies are similar to those used for a patient with increased intracranial pressure. So what would be the initial priority of care for KD upon admission to the emergency department? First, you would ensure a patent airway, and then your initial care of the patient with a head injury should include stabilizing the cervical spine, administering oxygen via non-rebreather masks, establishing IV access with 2 large bore catheters to infuse normal saline or lactated ringers, intubation if the GCS is below 8, control external bleeding with sterile pressure dressing, and remove the patient's clothing. Ongoing monitoring of the patient with a head injury during the emergent phase should include maintaining patient warmth using blankets, warm IV fluids, overhead warming lights, and warm humidified oxygen, ongoing monitoring of vital signs, level of consciousness, oxygen saturation, cardiac rhythm, Glasgow Coma Scale, pupil size and reactivity, and assess for rhinorrhea, otorrhea, and scalp wounds. Anticipate the need for intubation if the gag reflex is impaired or absent. Assume that there's a neck injury if there's a head injury, and administer fluids cautiously to prevent a fluid overload and increasing intracranial pressure. The principles for caring for patients with a head injury include taking measures to prevent secondary injury by treating cerebral edema and managing increased intracranial pressure, timely diagnosis and surgery if necessary. For the patient with concussion and contusion, observation and management of increased intracranial pressure are the primary management strategies. The treatment of skull fractures is usually conservative. For depressed fractures and fractures with loose fragments, a craniotomy is necessary to elevate the depressed bone and remove the free fragments. If large amounts of bone are destroyed, the bone may be removed, called a craniectomy, and a cranioplasty will be needed at a later time. In cases of large acute subdural and epidural hematomas, or those associated with significant neurologic impairment, the blood must be removed through surgical evacuation. A craniotomy is generally performed to visualize and allow control of the bleeding vessels. Burr hole openings may be used in an extreme emergency for a more rapid decompression, followed by a craniotomy. A drain may be placed post-operatively for several days to prevent reaccumulation of blood, and in cases where extreme swelling is expected, such as DAI and hemorrhage, a craniectomy may be performed where a piece of the skull is removed to reduce the pressure inside the cranial vault, thus reducing the risk of herniation. For nursing assessment, the subjective data that you should collect includes past health history, such as the mechanism of injury, whether it's a motor vehicle collision, sports injury, industrial accident, assault, or fall, and any medications such as anticoagulant use. In addition, the following important health information is related to pertinent functional health patterns. So for health perception, health management, find out about the use of alcohol or recreational drugs or other risk-taking behaviors. Cognitive perceptual, ask about headache, mood or behavior changes, mentation changes, aphasia, dysphagia, impaired judgment. And for coping stress tolerance, find out about fear, denial, anger, aggression, and depression. Katie's past medical history is negative except for the birth of 2 children. Her family denies any drug or alcohol use. She was not taking any anticoagulant medications. What objective data will you access KD for when she's admitted to the ICU after surgery? Well, hopefully you said that you would look at altered mental status and look for lacerations, contusions, abrasions, hematoma, battle sign, periorbital edema and ecchymosis, otorrhea, or exposed brain matter. You'd also look for rhinorrhea, impaired gag reflex, inability to maintain a patent airway, impending herniation signs such as altered or irregular respiratory rate and pattern. You'd look for impending herniation by assessing for Cushing's triad, which again is systolic hypertension with widening pulse pressure and bradycardia with full bounding pulse and irregular respirations. For GI, you'd look at vomiting, especially projectile, and bowel incontinence, and you'd ask about bladder incontinence as well. For reproductive area, you would ask about any uninhibited sexual expression. For neurologic, you'd ask about altered level of consciousness, seizure activity, pupil dysfunction, and cranial nerve deficits. For musculoskeletal, you would look for motor deficits and impairment, weakness, palmar drift, paralysis, spasticity, decorticate or decerebrate posturing, muscular rigidity and increased tone, flaccidity, and ataxia. Other possible diagnostic findings that you might have include the location and type of the hematoma, edema, skull fracture and or foreign body on CT scan or MRI, an abnormal EEG, positive toxicology screen or alcohol level, increased or decreased blood glucose level, and increased intracranial pressure. KD arrives in the ICU with a head dressing and a Jackson Pratt drain in place. She responds to painful stimuli by withdrawing but does not follow commands. What nursing diagnosis related to KD's neurostatus would be most appropriate when planning her care? I would suggest risk for ineffective cerebral tissue perfusion related to interruption of cerebral blood flow associated with cerebral hemorrhage, hematoma, and edema, hyperthermia related to increased metabolism, infection, and hypothalamic injury, impaired physical mobility related to decreased level of consciousness, anxiety related to abrupt change in health status, hospital environment, and uncertain future. And potential complications would include increased intracranial pressure related to cerebral edema and hemorrhage. Your overall goals would be to maintain adequate cerebral oxygenation and perfusion, remain normothermic, achieve control of pain and discomfort, be free from infection, have adequate nutrition, and maintain maximal cognitive, motor, and sensory function. One of the best ways to prevent head injuries is to prevent car and motorcycle collisions. The use of helmet by cyclists has led to fewer TBIs. The use of car seat belts and the use of child car seats are also associated with reduced TBI mortality rates. Be active in campaigns that promote driving safety and speak to driver education classes regarding the dangers of unsafe driving and the driving after drinking alcohol and using drugs. The use of seat belts in cars and the use of helmets for riding on motorcycles are the most effective measures for increasing survival after crashes. The wearing of protective helmets for lumberjacks, construction workers, miners, horseback riders, bicycle riders, snowboarders, and skydivers is also recommended. Also, individuals who are at risk for falls, such as older adults, should be evaluated for safety in their home, as falls are the second leading cause of head injuries. You invite KD's family to come into the room once you have her settled in. What would be important to explain to the family at this point? Well, begin with talking about maintaining cerebral perfusion and the goal of maintaining oxygenation and preventing secondary lack of oxygen or ischemia. Surveillance or monitoring for changes in neurostatus is very important because the patient's condition can deteriorate rapidly, necessitating emergency surgery. Because of the close association between hemodynamic status and cerebral perfusion, be aware of any coexisting injuries or conditions. Perform neurologic assessments at intervals based on the patient's condition. The Glasgow Coma Scale is useful in assessing the level of consciousness. Indications of a deteriorating neurologic state, no matter how subtle, such as decreasing level of consciousness or decreasing motor strength, should be reported to the healthcare provider. Monitor the patient's condition closely. Explain the need for frequent neurologic assessment to both the patient and the caregivers or the visitor's family. Behavioral manifestations associated with head injury can result in a frightened, disoriented patient who is combative and resists help. Your approach should be calm and gentle. A family member may be available to stay with the patient and thus prevent increasing anxiety and fear. One of the most important needs for the caregiver and family members is the acute injury phase is information about the patient's diagnosis, treatment plan, and the rationale for your interventions. The major focus of nursing care for the brain-injured patient relates to increased intracranial pressure. However, there may be problems that require specific nursing intervention. Eye problems may include loss of the corneal reflex, periorbital ecchymosis, and edema, and diplopia. Loss of the corneal reflex may necessitate administering lubricating eye drops or taping eyes shut to prevent abrasion. Periorbital ecchymosis and edema decrease with time, but cold and later warm compresses provide comfort and hasten the process. Diplopia can be relieved by use of an eye patch. A consult with an ophthalmologist should be considered. Hyperthermia may occur from injury to or inflammation of the hypothalamus. Elevations in body temperature can result in increased cerebral blood flow, cerebral blood volume, and increased intracranial pressure. Increased metabolism secondary to hyperthermia increases metabolic waste, which in turn produces further cerebral vasodilation. Avoid hyperthermia with the goal of 36 to 37 degrees centigrade as the standard of care. Use interventions to reduce temperature in conjunction with sedation as necessary to prevent shivering. If CSF rhinorrhea or otorrhea occur, inform the physician immediately. The head of the bed may be raised to decrease the CSF pressure so that a tear can seal. A loose collection pad may be placed under the nose or over the ear. Do not place a dressing in the nasal or ear cavities. Instruct the patient not to sneeze or blow their nose. Nasogastric tubes should not be used, and nasotracheal suctioning should not be performed on these patients due to the high risk of meningitis. Nursing measures specific to the care of the immobilized patients, such as those related to bladder and bowel function, skin care, and infection, are also indicated. Nausea and vomiting may be a problem and can be alleviated by antiemetic drugs. Headache can usually be controlled with acetaminophen or small doses of codeine. If the patient's condition deteriorates, intracranial surgery may be necessary. A burr hole opening or craniotomy may be indicated depending on the underlying injury that is causing the symptoms. The emergency nature of the surgery may hasten the usual preoperative preparation. Consult with the neurosurgeon to determine specific preoperative nursing measures. The patient is often unconscious before surgery, making it necessary for the family member to sign the consent form. This is a difficult and frightening time for the patient's caregiver and family and requires sensitive nursing management. The suddenness of the situation makes it especially difficult for the family to cope. KD survives the initial traumatic brain injury and surgery. She's hemodynamically stable, extubated, and breathing on her own. She opens her eyes spontaneously and follows commands. She remains confused and restless. She also has some balance and motor deficits. She is dependent on others for activities of daily living. The family asks what the next step in her care will be and if she will ever return to her original self. How will you respond? The patient is generally ready now for acute rehabilitation. Once the condition has stabilized, the patient is usually transferred for acute rehab management. There may be chronic problems related to motor and sensory deficits, communication, memory, and intellectual functioning. Many of the principles of nursing management of the patient with a stroke are appropriate for these patients. Conditions that may require nursing and collaborative management include poor nutrition status, bowel and bladder management, spasticity and dysphagia, deep vein thrombosis, and hydrocephalus. The patient's outward appearance is not a good indicator of how well the patient will ultimately function in the home or work environment. The outward physical appearance does not necessarily reflect what happened in the brain. Seizure disorders are likely seen in about 5% of patients with a non-penetrating head injury. Seizures are most likely to develop during the first week after the head injury. Some patients, though, may not develop a seizure disorder until years after the initial injury. Anti-seizure drugs may be used prophylactically to manage post-traumatic seizure activity. The mental and emotional sequelae of brain trauma are often the most incapacitating problems. One of the consequences of TBI is that the person may not realize that a brain injury has occurred. Many of the patients with head injuries who've been comatose for more than 6 hours undergo some personality change. They may suffer loss of concentration and memory and defective memory processing. Personal drive may decrease, apathy may increase, euphoria and mood swings along with the seeming lack of awareness of the seriousness of the injury may occur. The patient's behavior may indicate a loss of social restraint, judgment, tact, and emotional control. Progressive recovery may continue for 6 months or more before a plateau is reached and a prognosis for recovery can be made. Specific nursing management in the post-traumatic phase depends on specific residual deficits. In all cases, the family must be given special consideration. They need to understand what is happening and be taught appropriate interaction patterns. Provide guidance and referrals for financial aid, child care, and other personal needs. Assist the family in involving the patient in family activities whenever possible. Help the patient and family develop and maintain hope. The family often has unrealistic expectations of the patient as the coma begins to recede. The family expects full return to pre-trauma status. In reality, the patient usually experiences a reduced awareness and ability to interpret environmental stimuli. Prepare the family for the emergence of the patient from coma and explain that the process of awakening often takes several weeks. Arrange for social work and chaplain consultations for the family in addition to providing open visitation and frequent status updates. When it comes time for discharge planning, the caregiver, family, and patient may benefit from specific post-hospitalization instructions to avoid family-patient friction. Special no policies that may be appropriately suggested by the neurosurgeon, neuropsychologist, and nurse include no drinking of alcoholic beverages, no driving, no use of firearms, no work with hazardous implements and machinery, and no unsupervised smoking. Family members, particularly spouses, go through role transition as the role changes from that of spouse to that of caregiver. The expected outcomes for a patient with a head injury will be maintain normal cerebral perfusion pressure, achieve maximal cognitive, motor, and sensory function, and experience no infection or hyperthermia. Let's do one question. The nurse is caring for a patient after a head injury. How should the nurse position the patient in bed? Prone with the head turned to the right side, high Fowler's position with the legs elevated, supine position with the head on two pillows, or side lying with the head elevated 30 degrees.